Okay, it's the third part of hepatology, gastroenterology, hepatology. So, first thing that comes is liver function test, LFT interpretation. So, bilirubin is derived. Bilirubin is derived from the breakdown of hemoglobin in the red blood cells within the reticuloendothelial system, unconjugated, that is, liver conjugates bilirubin, which makes it water soluble, excreted in the urine. So this conjugated bilirubin excreted in the urine. Normal total cellular bilirubin is measured. However, the unconjugated indirect bilirubin and conjugated direct bilirubin. So conjugate is direct and conjugate is indirect. Albumin is a sensitive marker of hepatic function, but not useful in the acute stages, as it has a half-life of long half-life of 120 days. Transfers usually either alanine amino transfers ALT or aspartate amino transfers AST. Rarely does a laboratory routine provide both. These enzymes normally reside inside the cell in cytoplasm, inside the liver cells, so raised levels usually represent hepatocellular damage. ALT is more specific to the liver, and AST is also found in the cardiac and smooth muscle and red blood cells. Very high levels of AST or ALT, as in AST. No, it's very high levels of transaminase, like more than 1,000, suggest drug-induced hepatitis. Example: paracetamol, acute viral hepatitis, or ischemic, or rarely autoimmune hepatitis. So all these hepatitis can present ALT of more than 1,000. So the ratio of AST to ALT can give some extra clues as to the cause. For example, in chronic liver disease, ALT is more than AST, and that is ALT is SGPT. SGPT is more than SGOT. Once it is established, AST is more than ALT. The extremes of the ratio of ASTs to ALT can also be helpful. More than 2, like AST more than 2 times of ALT is suggestive of alcoholic liver disease, and less than 1 is non-alcoholic liver disease. Okay, GGT also related to the bile ducts. Typically elevated in cholestasis with alkaline phosphate elevated as well, but if alkaline phosphate is normal, suggests induction of hepatic metabolic enzymes like alcohol or enzyme inducing drugs. So if GGT is high and alkaline phosphate is normal, that shows hepatic metabolic enzyme alcohol can be the cause. Okay, ALP. Alkaline phosphate comes mainly from the cell lining the bile ducts, but also in the bones. Marked increase is typical of cholestasis, often with elevated GGT or bone disorder, usually normal GGT. So in elevated GGT and this alkaline phosphate is ALP plus GGT, basically means cholestasis, and just ALP and normal GGT is like bone turnover, bone disorder. So isoenzyme analysis may help identify source, and it's physiologically increased when there is increased bone turnover, like adolescence, and is elevated in the third trimester of pregnancy raised by the placenta. So when bilirubin is increased and no bilirubin in urine dipstick, it actually means unconjugated bilirubin. So unconjugated bilirubin is not soluble in water, hence can't appear in the urine. So there's no bilirubin in urine. So that's unconjugated bilirubin. So there's a demonstration of what really happens. Like in hepatocellular damage, this ALT, AST is like a lot, and little or none for cholestasis and infiltration, little or none of AST-ALT. And in case of alkaline phosphate or GGT, 0 to a bit, cholestasis a lot, infiltration a lot, bilirubin plus 1 plus to 3 plus in both of them, a little on infiltration. Coming to hepatomegaly, common causes of hepatomegaly, as we know, is cirrhosis, early disease, but later liver size decreases, associated with non-tender from liver. Malignancy can cause metastatic spread or primary spread associated with the heart irregularly edged liver. Um, right heart failure, firm, smooth, tender liver edge may be pulsatile as well. Hepatomegaly plus Dupuytren's contracture plus peritonitis, alcoholic liver disease. Okay, so other causes of hepatomegaly can be abscess, pyogenic or amoebic, glandular fever, hematological malignancies, hemochromatosis, heart disease, malaria, primary biliary cirrhosis, sarcoidosis, amyloidosis, viral hepatitis. And for hepatic encephalopathy, the rates that are there, grade 4 is coma, basically unresponsive to verbal or noxious stimuli. Grade 3 is somnolence to semi-stupor, but responsive to verbal stimuli, confusion, gross disorientation. Grade 2 is lethargy or apathy, minimal disorientation for time or place, subtle personality change, inappropriate behavior. And grade 1 is trivial lack of awareness, euphoria or anxiety, shortened attention span, impaired performance, and addition of subtraction. Next is hepatosplenomegaly. So both liver and spleen are expanding, becoming bigger. So congestive and infectious. Infectious reason can be glandular fever or malaria, infective hepatitis, Kala-Azar. And for congestive is CLD plus portal hypertension, congestive heart failure, congestive pericarditis, Budd-Chiari syndrome. This will show hepatosplenomegaly. Okay. And hematological can be lymphoma, myeloproliferative disorder like CML, anemia, storage disorders like amyloidosis, low glycogen storage disease, Gaucher's disease. All three can cause hepatosplenomegaly. Next is alcoholic hepatitis. Commonly occurs after a prolonged period of alcohol abuse or return to alcohol after a period of abstinence. So features can be increased serum transaminase, macrocytosis, thrombocytopenia, poor hepatic synthetic function, leukocytosis irrespective of infection, increased acute phase reactants, AST by ALT more than 2. This is the important one. Liver enzymes do not exceed 500, so this is also very important. More than 2, but do not exceed 500. It's within that. Discriminant dysfunction, malnutrition, jaundice, fluid retention, and encephalopathy are associated with poor outlook. The discrimination function can be used to identify people for treatment. Those who have DF more than 32 have 1 month mortality rate of 50%. They may benefit from corticosteroid pentoxifylline. Anyway, that's just there's a equation as well. DF equals to 4.6 into PT minus control bilirubin. Okay, Zeev syndrome is it occurs in patients with excessive alcohol consumption with hemolysis and severe hyperlipidemia, abdominal pain, transient mild raised bilirubin. It usually occurs in males and resolves once alcohol consumption is stopped. A very important topic of autoimmune hepatitis. It's actually a cause of unknown etiology, which is most commonly seen in young females. So females. Recognized association include other autoimmune disorders, hypergammaglobulinemia, and HLA-B8 DR3. 60% of DR3, remember that. 60% of patients have chronic hepatitis that may mimic viral hepatitis, but without serologic evidence of viral infection. 3 types of autoimmune hepatitis have been characterized according to the types of circulating antibodies present. For example, type 1 can be ANA or anti-smooth muscle antibody positive, affecting both adults and children. Type 2 is anti-liver kidney microsomal type 1 antibody LKM1, affects children only. And type 3 is soluble liver kidney antigen, affects middle-aged adult. More than 60% remission with steroids, but relapses 80%. Azathioprine is an alternative. So deranged LFT, secondary amenorrhea, as we said, it's more common in females. So delayed LFT, secondary amenorrhea in a young female, leads to autoimmune hepatitis. So the features that can be there may present with signs of chronic liver disease, acute hepatitis like fever, jaundice, amenorrhea in women, and ANA, SMA or LKM1 antibodies positive, raised IgG levels. For children, it's LKM1, and for adults and children, both SMA, ANA, soluble liver kidney antigen is also there. So liver biopsy, if done, it can show inflammation extending beyond the limiting plate piecemeal necrosis, bridging necrosis. Management can be steroid, or like other immunosuppressants, or liver transplantation. Important topic of non-alcoholic fatty liver disease is now the most common cause of liver disease in the developed world. It's non-alcoholic, by the way. It's largely caused by obesity and describes a spectrum of disease ranging from steatosis, that is fat in the liver, steatohepatitis, fat with inflammation, non-alcoholic steatohepatitis, and progressive disease may cause fibrosis and liver cirrhosis. So NFL is thought to represent the hepatic manifestation of the metabolic syndrome, so it's like the hepatic part of the metabolic syndrome, and hence insulin resistance is thought to be the key mechanism leading to steatosis. So fat in the liver, the main key mechanism is thought to be insulin resistance. So NAFLD, okay. Non-alcoholic steatohepatitis is a term used to describe liver changes. It's a term used to describe liver changes like those seen in alcoholic hepatitis. This is the second one, steatohepatitis. So it's a term used to describe liver changes in those seen in alcoholic hepatitis in the absence of any history of alcohol abuse. Similar to that. Okay, it's relatively common and affect around 3 to 4% of general population. The progression of disease in patients with NASH may be responsible for a proportion of patients previously labeled as cryptogenic cirrhosis as well. So obesity, type 2 diabetes mellitus with abnormal LFTs, non-alcoholic fatty liver disease. Okay, so associated factors can be like obesity, hyperlipidemia, type 2 diabetes mellitus, jejunal bypass, sudden weight loss, starvation. Features can be visually asymptomatic hepatomegaly is seen. LT is typically greater than AST, so since it's about the hepatic part, and increased echogenicity in ultrasound. The mainstay of treatment is lifestyle changes, particularly weight loss and monitoring. Screen for advanced liver fibrosis every 3 years using the enhanced liver fibrosis ELF blood test. Okay. Consider pioglitazone or vitamin E for advanced liver fibrosis, whether they have DM or not. Okay, can be considered. Very important topic of liver biopsy, and we know that every time the question comes about what is the indication of indication, contraindication, whatever. So liver biopsy and abscess drainage, or percutaneous liver biopsy contraindication. When you're not gonna do it? If there's deranged clotting, or INR more than 1.4, low platelets less than 60, anemia, bile duct obstruction, hereditary cyst, hemangioma, uncooperative patient ascites. That's when you're not going to do it. Okay, pyogenic liver abscess management, drainage, needle aspiration or catheter should always be performed. Amoxicillin, ciprofloxacin, metronidazole is the drug of choice, and penicillin allergic. If penicillin allergic, give cipro and clindamycin. Okay, a very common infection, hepatitis B. What happens here? Okay. So basically, it's the basics over here. Incubation period 6 to 20 weeks. It's a double-stranded DNA virus, and then spread by body fluid and vertical, like among mother and child. Chronic disease in 5 to 10%. Vaccination available. So chronic complications can be chronic infection, fulminant liver failure, hepatocellular carcinoma, GBS, glomerulonephritis, like membranous proliferative, if you remember that, polyarteritis nodosa, cryoglobulinemia, hepatitis C more than B. So immunization is also there, like contains hepatitis B antigen absorbed into aluminum hydroxide adjuvant, and is prepared from yeast cells using recombinant DNA technology. Most adults get 3 doses of the vaccine with the recommendation for a one-off booster 5 years following the initial primary vaccination. At-risk groups who should be vaccinated include healthcare workers, intravenous drug users, sex workers, close family contacts of an individual with hepatitis B, individuals receiving blood transfusions regularly, CKD patients who may soon require renal replacement therapy, prisoners, CLD patients. Around 10 to 15% of adults fail to or respond poorly to the three doses of the vaccine. Risk factors include over 40 years obesity, smoking, alcohol excess, and immunosuppression. So testing for anti-HBs is only recommended for those at risk of occasional exposure, healthcare workers, and patients with CKD. In these patients, the anti-HBs level should be checked 1 to 4 months before primary immunization. The table, 1 to 4 months after primary immunization. The table below shows how to interpret anti-HBs levels. So in case you've given it this month, you're gonna check it after 3 to 4 months, 1 to 4 months, the anti-HBs. So if it's more than 100, it's adequate response, no further testing required. Should still receive booster at 5 years. And 10 to 100, suboptimal response. One additional vaccine dose should be given. If immunocompetent, no further testing is required. Less than 10, non-responder. Test for past or previous infection. Give further vaccine course 3 doses again with testing following. If still fails to respond, then HBIG would be required for protection if exposed to the virus. Okay, so management for chronic hepatitis, management for hepatitis B. Chronic hepatitis B is not curable, but it's treatable. Treatment can help prevent cirrhosis, liver failure, and liver cancer by reducing hepatitis B viral load and the loss of HBAG, either with or without detection of anti-HBe, while improving liver enzyme levels. So what you do is offer antiviral treatment with HBV DNA more than 2000. So more than 2000, that's when you offer the treatment. And abnormal ALT on 2 consecutive tests conducted 3 months apart. Offer antiviral treatment to adults who with cirrhosis and detectable HBV DNA regardless of HBeAg status, HBV DNA and ALT levels. PEG interferon is recommended as an option for the initial treatment of adults with chronic hepatitis B, like HBeAg positive or negative. Interferon alpha 2b is also still used in children. Antiviral tenofovir anticover is still in use. Not recommended telvivurin, lamivudine, adifovir, all these. Okay, hepatitis B and pregnancy. So all pregnant women are offered screening for hepatitis B. Offer tenofovir to women with HBV DNA greater than 10 to the power 7 in the third trimester to reduce the risk of transmission of HBV. So it's in the third trimester, that's when you want to give this thing. Stop 4 to 12 weeks after the birth unless the mother meets criteria for long-term treatment. Baby should receive a complete course of vaccination, passive immunization plus immunoglobulin. Hepatitis B cannot be transmitted via breastfeeding in contrast to HIV, and antivirals are also breastfeeding safe, so that's good. Serology is like a dying art from which still occurs at regular intervals and medical exams, so this still comes in the exam. So the HBsAg is the first marker to appear and causes the production of anti-HBs. So that's the first thing that comes up in the blood. HBsAg normally implies acute disease present for 1 to 6 months. So this is acute disease, that's when it's positive. If HBsAg is present for more than 6 months, it implies chronic disease. It's already chronic. Anti-HBs implies immunity, either exposure or immunization from vaccine or the disease itself. So anti-HBc core antigen. Okay, so anti-HBc level implies previous or current infection, and IgM anti-HBc appears during acute or recent hepatitis B infection and is present for about 6 months. So C means current or recent. So remember this, C is current or recent. HBeAg results from breakdown of core antigen from infected liver cells and is therefore a marker of infectivity. Okay, example of results. Previous immunization. If the person is previously immunized, anti-HBs will be positive and all others will be negative. So this is only for immunization, vaccine. Previous hepatitis B. 6 months ago, but not a carrier anymore. So it will show anti-HBC BC positive, so it's since previous hepatitis more than 6 months, and HBCG negative, so it's not a carrier anymore. Previous hepatitis B and now a carrier, so it will be all positive, anti-HBC positive and GSIG positive. Alright, so moving to hepatitis C now. Hepatitis C is believed to affect 0.5% of the UK population, and it's an RNA virus, and hepatitis B is DNA and hepatitis C is RNA. Risk of transmission during a needle stick injury is about 2%, where the risk of transmitting the virus during sexual intercourse is probably less than 5%. Vertical transmission from mother to child is about 6%. Breastfeeding is not contraindicated in mothers with hepatitis C. After exposure to the hepatitis C virus, less than 20% of patients develop an acute hepatitis. Less than 20%. So this is not as much as hepatitis B. Complications can be chronic infection, 80 to 85%. Only 15 to 20% of patients will clear the virus, and hence the majority will develop chronic hepatitis C. Cirrhosis, 20-30%. Hepatocellular carcinoma and crack level anemia. What about the management? HCV infection is cured in more than 99% of people who achieve a sustained viral response. Antiviral combination therapy, all people with chronic HCV infection should be considered for antiviral therapy, which is always initiated by a specialist. The treatment regime, duration of treatment and effectiveness will depend on the HCV genotype and subtype, viral load, severity of liver disease, and the person's comorbidities and ability to tolerate treatment. Combination dual therapy usually consists of weekly self-administered subcutaneous picoylated interferon alpha and daily oral ribavirin. So these two. People with HCV genotype 1 typically have a longer treatment course than other genotypes and have a worse prognosis. They may be considered for treatment with triple therapy involving the addition of a protease inhibitor, which has improved treatment success rates considered with dual therapy. Liver transplantation is the treatment of choice for people with end-stage liver disease. Okay. Next is the treatment side effects. Ribavirin, as we said, interferon alpha and ribavirin. Hemolytic anemia, cough. Women should not become pregnant with 6 months of stopping ribavirin, as it's teratogenic. So you have to stop and then wait for 6 months and then try for pregnancy. Interferon alpha is will give flu-like symptoms, depression. These two I've seen before. Fatigue and leukopenia, thrombocytopenia can also occur. Liver cirrhosis now was a very important major topic. A lot of patients will be showing up at wards with liver cirrhosis, known case or no unknown. Okay, micronodular cirrhosis is associated with alcoholic liver disease. Macronodular cirrhosis is associated with chronic hepatitis, and something important. Granuloma formation is not classically seen in cirrhosis. Diagnosis guidelines 2006 recommended either offer transient elastography or acoustic radiation from force impulse imaging for NFLD, or offer transient elastography to diagnose cirrhosis in hepatitis C. So risk stratification, calculating the model for end-stage liver disease every 6 months and considering MELD score for more than 12 as an indicator of high risk of complications of cirrhosis because of the complicated nature of the, you'll need to be known. Okay, so child per classification is there for the severity of liver cirrhosis. As you know, this BAPEA or I like to remember it with Bape, like Mbappe, but spelling is not exactly Bape. Just remember that. Bilirubin, albumin, prothrombin time, and encephalopathy and ascites. So B for bilirubin, so 15 to 17 is usually normal. If you remember 34 and 50, so less than 34 is 1, more than 50 is 3, in the middle 2. Albumin 30 to 50 is normal, more than 35 is good, and that's 1. And 2 is 28 to 35, less than 28 is 3. PT is like 4 to 6, you have to remember. And encephalopathy non-mild marked. SID is non-mild marked, so less than 7 is A, grade A, and less than 7 to 9 is B, and more than 9 is C. Okay, hepatocellular carcinoma is the third most common cause of cancer worldwide. So worldwide most common hepatitis B. Most common cause of this cancer is hepatitis B worldwide, and Europe is hepatitis C. So the main risk factor for developing HCC is liver cirrhosis. For example, secondary to hepatitis B, C, alcohol, hemochromatosis, or primary biliary cirrhosis. Other risk factors can be alpha-1 antitrypsin deficiency, hereditary tyrosinosis, glycogen storage disease, aflatoxin, drugs like OCP and anabolic steroids, PCT, sex, diabetes mellitus, and metabolic syndrome. Okay. So let's see about the features. Tense present late. Features of liver cirrhosis or failure: jaundice, ascites, right upper quadrant, pain, hepatomegaly, pruritus, splenomegaly. Possible presentation is decompensation in a patient with chronic liver disease, so it means acute deterioration in a patient who's already known CLD. So what are the management options? Early disease surgical resection, liver transplantation, radiofrequency ablation, transarterial chemoembolization, sorafenib, as well a multikinase inhibitor. Screening with ultrasound plus minus AFP should be considered for high risk groups such as patients' liver cirrhosis secondary to hepatitis B and C or hemochromatosis, men with liver cirrhosis secondary to alcohol. Important topic: hepatorenal syndrome, one of the complications of CLD, you can see. Okay, so hepatorenal syndrome, how does it present is important. Refers to the development of acute renal failure in a patient who has advanced liver disease and who has no identifiable cause of intrinsic renal disease. So there's no other cause of renal disease, but it's happening with a person known with a known CLD. Usually represents the end stage of a sequence of reductions in the renal perfusion induced by increasingly severe hepatic injury. So splanchnic vasodilation appears to play an important role in the decline in the renal function in hepatic disease. So splanchnic vasodilation means lesser blood will be reaching the kidney and all that. Diagnostic criteria have been proposed for the hepatorenal syndrome: chronic or acute hepatic disease with advanced hepatic failure and portal hypertension, creatinine more than 1.5 that progresses over days to weeks, absence of any other apparent cause for renal disease, including shock, active sepsis, current nephrotoxic drugs, and the absence of ultrasonographic evidence of obstruction or parenchymal renal disease. So there's no CKD or anything. Okay, it's particularly important to exclude spontaneous bacterial peritonitis, which is complicated with renal failure, and urine sodium less than 10 milliequivalent, and protein excretion less than 500 per day. Lack of improvement in renal function after volume excretion with 1.5 liter of acid saline. So giving saline and it's not improving, so it's not pre-renal. Hepatorenal syndrome have been categorized into two types. So two types of the type 1 is rapidly progressive, and type 2 is slowly progressive. So double of serum creatinine to 21 or more than 2.5, or halving of the creatinine clearance to 20, less than 20, or a period of 2 weeks, less than 2 weeks. Very poor prognosis, and slow progressive HRS, prognosis poor, but patients may live for longer. Okay, so management is not really difficult. The ideal treatment is liver transplantation, but patients are often too unwell to have surgery, and there's shortage of donors. Management option can be vasopressin analog like terlipressin. Have a growing evidence base supporting their use, so terlipressin is the main treatment. They work by causing vasoconstriction of the splanchnic circulation. Volume expansion with 20% albumin can also help. Transjugular intrahepatic portosystemic shunt tips can help. Okay, Wilson's disease. Okay, so Wilson's is also an important disease, autosomal recessive disorder characterized by excessive copper deposition in the tissues. Metabolic abnormalities include increased copper absorption from the small intestine or decreased hepatic copper excretion. So Wilson's disease is caused by a defect in the ATP7B gene located on chromosome 13. The onset of symptoms is usually 10 to 25 years. Children usually present with liver disease, whereas the first sign of disease in young adults is often neurological disease. So liver and kidney together, it's a hint. Features can be result from excessive copper deposition in the tissues, especially the brain, liver, and cornea. So liver hepatitis, no cancer, it's only cirrhosis. Neurological, speech, and so dysarthria you'll see. Speech problems and behavioral problems and neuropsychiatric are the first manifestation. Tremor and chorea is also there. Tremor and chorea. Kyphoscoliosis rings in the cornea, renal tubular acidosis, especially Fanconi syndrome, hemolysis, and blue nails. All these are important if you remember. Combination of Parkinsonism and chronic liver disease in young patients. So you'll see some tremor and chorea, Parkinsonism in young patient, chronic liver disease. So diagnosis can be decreased serum ceruloplasmin, which is the protein which carries copper, and increased 24-hour urinary copper excretion. Slit lamp, you can see Kaiser-Fletcher ring, and penicillamine is the management which chelates copper 1.5 to 2 gram per day in divided dose, then like this. That's how you give it per day, then this. Triantine and zinc can also help. Okay, coming to ascites, a very important thing to see in chronic liver disease. So how do you approach ascites? It's also very important. So in ascites, you know that there's two things to check, if it's transudate or exudate. So this is the old classification. How you check exudate is like when protein is more than 30 gram per liter, and the cause can be intraabdominal tuberculosis and pancreatitis or hepatic peritoneal malignancy, all these things, and mainly infectious and other causes. Transudate is basically less than 30 gram per liter. Cirrhosis and portal hypertension, nephrotic syndrome, cardiac failure, Budd-Chiari syndrome, mixed edema, all this can cause transudative ascites. However, the serum ascites albumin gradient has now largely replaced this concept, and the best single test for classifying ascites into portal hypertension and non-portal hypertension. So SAAG more than 11 is portal hypertension, and less than 11 is non-portal hypertension. So 11 is the magic number, if you remember. The terms high albumin gradient and low albumin gradient should replace the terms transudative and exudative in the description of ascites. So that really happens. So SAAG is basically serum albumin minus ascitic albumin. So how much albumin is there in the serum minus how much albumin is there in the ascites fluid. So SAAG more than 11 is either meaning that there's less albumin in the ascites or there's more albumin in the serum. Okay. So how this is coming to happen, sometimes you have to realize. So there can be like two mechanisms how this happens. This is about the pressure, hydrostatic pressure more in the vessels, and there's like less there, and sometimes there can be infiltration, there can be gaps through which the things come out. Anyways, I'm not going to details of that. So what you have to remember is the new classification of ascites. And so increased SAAG is serum albumin minus ascitic fluid albumin, cirrhosis, liver cirrhosis, then alcoholic hepatitis, schistosomiasis, fulminant hepatic failure, Budd-Chiari syndrome, acute or chronic portal vein obstruction, cardiac disease, spontaneous bacterial peritonitis, secondary to cirrhosis, and less than 11 causes. Will be nephrotic syndrome, protein-losing enteropathy, peritoneal carcinomatosis, tuberculosis, peritonitis, pancreatic duct leak, biliary ascites. To remember that. Next question is spontaneous bacterial. Next topic is spontaneous bacterial peritonitis. Most common infection in people with cirrhosis and are SBP. So, followed by UTI, pneumonia, bacteremia, and all that. Diagnosis can be done by paracentesis. Neutrophil count more than 250. Actually, IV antibiotics, according to local guidelines, many hospitals do recommend piperacillin, ceftazobactam. I think now it's cefotaxime. Step down to, so I'll just write here cefotaxime maybe. Step down to chlorotrimmoxazole to finish course when clinically improved. Prophylactic oral and ciprofloxacin or norfloxacin for people with cirrhosis. Ciprofloxacin as well. Prophylactic oral ciprofloxacin or norfloxacin with people. This is prophylaxis for people with cirrhosis or ascites with an acidic protein level of 15 gram or less until the ascites is resolved. Chlorotrimmoxazole is also being used in some hospitals. However, it's always recommended to follow your local hospital guidelines. Alcohol liver disease is a marker of poor progress in SBP. Coming to bile acid malabsorption, it's also important. We will be coming to bile acid diseases, and it's a cause of chronic diarrhea. It can result from malabsorption secondary to GI disease or be a primary disorder. Treatment with bile acid sequestrants is often ineffective. Okay. Type is type 1. Is bile acid malabsorption secondary to ileal resection or ileal inflammation. Type 2 is idiopathic bile acid malabsorption. Primary bile acid diarrhea. Type 3 is secondary to various GI disease like cholecystectomy or vacuotomy, SIB, overgrowth, radiation, enteropathy, all this. So bile acid malabsorption, you can do a CCAT test. It's a nuclear test, involves 2 scans a week apart and only very limited radiation exposure. Retention of the CCAT at 7 days is normally above 15%. Values less than that predict a response to bile acid sequestrants. CCAT test measures multiple cycles of bile acid excretion and reabsorption over 7 days. This test is not licensed in the USA and is underutilized when it's available. Fecal bile acid quantification on the 14C glycolic blood tests are no longer in routine use. Moving to the 4 syndromes which are like causing bilirubin to go up. Dublin-Johnson syndrome. Okay, so Dublin-Johnson syndrome, a benign autosomal recessive disorder resulting in hyperbilirubinemia, which is basically conjugated, and so Dublin-Johnson is conjugated, therefore present in urine. It's due to the defect in canalicular multispecific organic ionic anion transporter, like C-MOT, conjugate C protein. This causes defective hepatic bilirubin excretion. So increase of conjugated bilirubin, no elevation of liver enzyme, usually asymptomatic but may be diagnosed in early infancy based on laboratory tests infancy. Liver biopsy shows dark granules in the hepatocyte, though thought to be due to melanin deposition. Prognosis is good and treatment of the syndrome is usually unnecessary. Most patients are asymptomatic and have normal lifespans. Rotor syndrome is a rare, relatively benign autosomal recessive bilirubin disorder of unknown origin. It's a distinct disorder yet similar to Dublin-Johnson syndrome. Both these are cause an increase in conjugated bilirubin. So Dublin-Johnson rotor, they are all conjugated. It can be differentiated from Durbin-Johnson in some following ways. So, Rotor syndrome, Durbin-Johnson syndrome. Appearance of severe syndrome and appearance of liver is normal. Liver has black pigmentation. Gallbladder visualized by oral cholecystogram cannot be visualized. Increase in urine increase in less than 70% being isomer 1, normal with more than 80% being isomer 1. Coproporphyrin, normal urine contains more of isomer 3 than isomer 1. So hyperbilirubinemia, normal dipsticks urine analysis. So if in urine there is no bilirubin, it excludes Durbin-Johnson Rotor syndrome, as this produces conjugal bilirubinemia. So conjugated bilirubin will appear in urine. Conjugal Durbin-Johnson Rotor, DJR. DJR. Gilbert syndrome, it's typically inherited in autosomal recessive as well, like the previous two, and occasionally in an autosomal dominant depending on the type of mutation, characterized by defective bilirubin conjugation due to deficiency of UTP, glucuronyl transferase. The prevalence is approximately 1 to 2% in general population, and viral infections are common triggers for a rise in the bilirubin in patients with Gilbert's. Viral infections, okay. So isolated hyperbilirubinemia, of course, unconjugated, not in urine. So unconjugated, as in, like you can say, unsocial urine is the club. So unsocial, unconjugated. So jaundice may only be seen during an intercurrent illness. So it's like the club, social club, where conjugal people can go in. You can think like that. So unconjugated hyperbilirubinemia, not in urine. Jaundice may only be seen during an intercurrent illness. Investigation can be rise in bilirubin following prolonged fasting or IV nicotinic acid. No treatment is required. And the exact mode of inheritance is still a matter of debate. And the next is Crigler-Najjar syndrome. It's a rare disorder affecting the metabolism of bilirubin as well, which results in high levels of unconjugated bilirubin as well, and often leads to brain damage in infants. So CG is unconjugated. Okay. This syndrome is divided into type 1 and type 2, with the latter sometimes called Arias syndrome. These two types, along with Gilbert syndrome, Durbin-Johnson syndrome, and Rotor syndrome, make up the 5 known hereditary defects in bilirubin metabolism. Unlike Gilbert's, only a few hundred cases of CNS are known. This CNS. Typically, one is usually fatal, with only type 2 can survive to adulthood. So the syndrome is treated with liver transplantation. So there's no other options. Very important disease of primary sclerosing cholangitis, and the primary disease of unknown etiology characterized by inflammation and fibrosis of intra and extrahepatic bile ducts. Intra and extrahepatic bile ducts of inflammation and fibrosis. So association can be ulcerative colitis. 4% of patients with ulcerative colitis have PSC. 80% of patients with PSC have ulcerative colitis. So these both have good associations. Crohn's, much less common association with an ulcerative colitis, HIV. So MRCP is the diagnostic tool showing multiple beaded biliary stricture, giving a beaded appearance. And ERCP, when therapeutic intervention is likely needed, known strictures or symptoms and signs suggesting obstruction. ANCA may be positive. There is a limited role for liver biopsy, which may show fibrous obliterative cholangitis, often described as onion skin. And cholestasis, the features. Cholestasis, hepatomegaly, intermittent jaundice. Complications can be. The features are important because jaundice is there, hepatomegaly is there, cholestasis is there. ALP will be raised, bilirubin will be raised, maybe GGT will be raised. Cholangiocarcinoma in 10%. Increased risk of colorectal cancer. Patients usually die from complications related to SBC, secondary biliary cirrhosis, portal hypertension, cholangitis. Okay, management will be arsocol, basically ursodeoxycholic acid. is recommended for the management of primary biliary cholangitis. Including those with asymptomatic disease. It slows disease progression, but the effect on overall survival is uncertain. Cholestyramine is to relieve pruritus. Correction of deficiencies of fat-soluble vitamins like A, D, E, K, and percutaneous transhepatic balloon dilatation may be of benefit for dominant strictures. Liver transplantation. So what you're going to do is arsocol, as I've said, slows the disease progression and all that. Cholestyramine to relieve pruritus, and correction of deficiencies of fat soluble vitamins like A, D, E, K. Percutaneous transhepatic balloon dilatation may be of benefit for dominant strictures. Liver transplantation. Survival post-transplant is 90%, although rejection is high. Indication for transplantation. A very important question. High yield question is bilirubin more than 100, or okay, maybe it's not fully given. Recurrent bacterial cholangitis, ascites, refractory itching. Cholangiocarcinoma is a contraindication for transplantation. The most common cause of biliary disease in patients with HIV is sclerosing cholangitis due to infections such as CMV, Hepatosporia, and Macrosporia. PBC, previously known as primary biliary cirrhosis. Chronic liver disease disorder typically seen in middle-aged women is the AMA disorder. Female will be affected more. It's an autoimmune condition with HLA-DR8 association. 8. Amma lives in 8. Used to live in 8. Interlobular ducts become damaged by chronic inflammatory process and interlobular ducts, causing progressive cholestasis, which may eventually progress to cirrhosis. The classic presentation is itching and tiredness in a middle-aged woman. And association can be, remember, it's an autoimmune condition. So Sjogren's syndrome, 80%, rheumatoid arthritis, SL, systemic sclerosis, thyroid disease, membranous glomerulonephritis, RTA. Clinical features can be early, maybe asymptomatic, increased ALP, routine LFTs, or fatigue pruritus, cholestatic jaundice, and hyperpigmentation, especially over pressure points, xanthelasma, xanthomata, clubbing, hepatosplenomegaly, may progress to liver failure. AMA is anti-mitochondrial antibodies. AMA M2 subtype in 98% of patients are highly specific anti-nuclear RIM, anti-nuclear dot, or anti-centromere antibodies can frequently be sufficient to diagnose AMA negative IBC. Smooth muscle antibodies in 30% of people. Raised serum IgM. The role of imaging is largely to exclude alternative diagnosis, particularly biliary and infiltrative disease, so that for the vast majority, a screening ultrasound suffices. Attention to exclusion of primary sclerosing cholangitis and its mimics by MRCP is warranted for seronegative patients. Ultrasound is enough. For management, median survival is 7 to 10 years, but decreased to 2 years if jaundice is present. Pruritus, you give cholestyramine. So for pruritus, you give cholestyramine, and you also give fat-soluble vitamin supplementation, ADEK. Alcohol is contraindicated, of course. Ursodeoxycholic acid at a dose of 10 to 15 mg per kg per day improves bile flow and replaces toxic hydrophobic bile acid in the bile acid pool. It is the process of the biliary epithelium. Obeticholic acid acts as an agonist of the nuclear pharmacoid X receptor. It's a modified bile acid indicated in intolerance to UDCA, or those who fail to respond to UDCA. So if arsocol is non-responsive, you can give obeticholic acid. It's a modified bile acid, basically. Liver transplantation, if bilirubin is more than 100, and PBC is a major indication. And recurrence in graft can occur, but it's not usually a problem. 5-year survival post-transplant 80%. Despite extensive research, no role for immune suppression in PBC, except for when PBC overlaps with autoimmune hepatitis or AMA negative PBC. PBC M role is IgM, mitochondrial antibodies M2 subtype, and middle-aged females. And complications can be malabsorption, osteomalacia, coagulopathy, Sickle syndrome, Sjogren syndrome, occurs in 70% of cases, portal hypertension, ascites, facial hemorrhage, hepatocellular cancer, 20-fold in increase risk. Okay. Common GI surgical problems in MRCP, and Anal fissure will go through it quickly. These are longitudinal or elliptical tears of the squamous lining of the distal anal canal. If present for less than 6 weeks, they are predefined as acute, and chronic if present for more than 6 weeks. Around 90% of the anal fissures occur in the posterior midline. Okay. This is more associated with Crohn's disease. Okay, management of an acute anal fissure less than 6 weeks. Dietary advice would be high fiber diet with high fluid intake. Bulk forming laxatives are first line if not tolerated. Then lactulose should be tried. And lubricants such as petroleum jelly may be tried before defecation. Topical anesthetics, sitz baths, hip bath in hot water for 2 to 5 minutes, followed by cold water for 1 minute. Topical steroids do not provide significant relief. Okay, management of chronic anal fissure more than 6 weeks. The above technique should be continued. And topical GTN is the first line of treatment for chronic anal fissure. If topical GTN is not effective after 8 weeks, then consider a secondary referral should be considered for surgery or botulinum toxin. Okay, a very important topic for the exam, mesenteric ischemia, is primarily caused by an arterial embolism resulting in infarction of the colon. It's more likely to occur in areas such as the splenic flexure that are located at the borders of the territory supplied by the superior and inferior mesenteric arteries. Okay, so important. Top information: superior and inferior mesenteric arteries, splenic flexure. Okay, predisposing factors can be increasing age and atrial fibrillation. Other causes of emboli can be endocarditis and cardiovascular disease risk like smoking, hypertension, diabetes. Features can be abdominal pain, rectal bleeding, diarrhea, fever. Bloods typically show an elevated red blood cell count associated with acidosis. Meckel's diverticulum presents with intermittent marina anemia. Diagnosed with Meckel's scan or video capsule endoscopy. Meckel's diverticulum. Okay, science. Management can be mesenteric angiography is the diagnostic tool. Supportive care, laparotomy, and bowel resection can also be done. Okay, ischemic colitis is another important one. Although uncommon in the general population, ischemic colitis occurs with greater frequency in the elderly. It's the most common cause of bowel ischemia. Causes of the reduced blood flow can include decreased BP or local factors such as constriction of blood vessel or atheroma in the mesenteric vessel. So, usually followed. Okay. Barium enema examination shows disappearance of the semilunar folds, thumb printing, arrows, narrowing of the terminal ileum, arrowhead, and swelling of the ileocecal valve, and calcification. Okay. Diagnosis can be barium enema tends to be abnormal in 90%, showing thumb printing and indicative of mucosal edema. CT is the single best test after plain radiography. Colonoscopy is the diagnostic tool of choice. It shows petechiae, pallor, hyperemia, necrosis. Contrast enema with gastrographin confirmed thumb printing extending from the cecum, you can see, to the splenic angle and excluded an obstruction which in the distal colon. Retroperitoneal fibrosis, lower back pain is the most common presenting features, and association can be renal thyroiditis, previous radiotherapy, sarcoidosis, inflammatory abdominal aortic aneurysm, drugs, may be surgery. So that concludes for gastrointestinal diseases.